Dear colleagues, today I am presenting the case of a severe hydrocephalus with rapid onset. The detailed ultrasound images you are currently looking at belong to a female fetus at the 31st week of gestation who, at the previous routine ultrasound check performed 2 weeks earlier, was found to be completely normal. Hydrocephalus is actually the most frequently observed condition or structural anomaly of the central nervous system during the fetal period. It is a medical condition characterized by a significant dilation of the cerebral ventricles due to a specific alteration in the normal circulation of cerebrospinal fluid. It has an incidence ranging from 0.5 to 3 cases per thousand births and shows a slight predominance in females. Two main types are distinguished: an obstructive variant, which is caused by a blockage of the flow of cerebrospinal fluid, and a non-obstructive or communicating variant, which instead results from impaired absorption of the fluid itself. In the specific case of obstructive hydrocephalus, the blockage can occur at different levels. It usually affects the aqueduct of Sylvius, but sometimes it can also involve the outlets of the fourth ventricle. The most frequent causes are, in fact, stenosis of the aqueduct or possible alterations of the posterior cranial fossa, such as Dandy-Walker malformation or Chiari type 2 malformation. In the specific case under examination, we observe a massive ventricular dilation involving both lateral ventricles and the third ventricle, which we can see here dilated and visible, but also the cisterna magna, indicating an alteration of the posterior cranial fossa, along with severe thinning of the cerebral parenchyma, especially affecting the parieto-occipital region. The maximum size of the left lateral ventricle was 32 millimeters, thus presenting a picture of severe hydrocephalus. The right lateral ventricle, on the other hand, had a maximum size of about 32.2 millimeters. Ultrasound-wise, this therefore falls within the framework of severe hydrocephalus with a maximum diameter measurement greater than 15 millimeters. There are two other forms: mild, which is between 10 and 12 millimeters, and moderate, which is between 13 and 15 millimeters. In severe forms, there are often associated alterations, as in this case of the parenchyma, with ventricular ballooning, cortical thinning, sometimes macrocrania, which, as we will see, was actually not present in this case, with an altered ratio between biparietal diameter and cranial circumference, and sometimes clear signs of destruction and compression of the cerebral mantle, which in this case, in fact, were present. From an etiological point of view, while we have seen what the main causes of obstructive hydrocephalus are, in the case of communicating hydrocephalus, therefore due to impaired reabsorption, this often depends on supervening conditions such as intraventricular hemorrhages, congenital infections, subarachnoid hemorrhages, or actual alterations of the arachnoid granulations. So it falls within the scope of acquired causes, among which the most frequent are those of infectious origin, such as the torch complex, cytomegalovirus, toxoplasma, but also parvovirus B19, or indeed vascular causes, and more rarely due to exposure to teratogens or drugs. Other conditions, on the other hand, may be due to abnormal brain development, so on a dysgenetic basis, such as agenesis of the corpus callosum, cortical malformations, agenesis, cerebellar hypoplasia, or due to loss of parenchyma, thus ex vacuo. In this case, however, this was ruled out since the detailed morphological evaluation of the fetus was consistently found to be normal both during the second trimester screening and in the subsequent neurosonographic assessment performed here. Lastly, and more rarely, the condition may be associated with syndromic genetic conditions such as aneuploidies, microdeletions, duplications, or monogenic mutations. As we mentioned earlier, the biometric evaluation of the fetal skull in this case turned out to be normal, so there was no condition of macrocrania. But what is important is that, from a morphological point of view, hydrocephalus, in addition to involving the third ventricle, as we see in this case, shows along these transverse scans of the fetal brain a direct communication between the frontal horns of the lateral ventricles, thus presenting a picture that almost mimics a condition of septo-optic dysplasia and the absence, therefore, of a regular cavum septi pellucidai. In these cases, especially in conditions of severe hydrocephalus, it is always necessary to look for other signs of central nervous system abnormalities, such as agenesis of the corpus callosum, cortical alterations, anomalies of the posterior cranial fossa, or signs of vascular processes like hemorrhages, or signs of infection such as calcifications, cortical anomalies, or possible microcephaly. It is also always necessary to look for extracerebral signs, especially to rule out possible syndromic conditions, which in this case were not present. When evaluating the posterior cranial fossa, we observe a cerebellum that is normal in both size and morphology, but with a cisterna magna that appears dilated, with a maximum diameter of 18 millimeters. We can see a very significant thinning of the parenchyma in the occipital-parietal cortical regions, which is occurring precisely due to the massive ventricular dilation. We therefore also proceeded to conduct a more in-depth study using detailed sagittal sections. In this particular imaging view, we can clearly observe a corpus callosum that is present and of a normal size, but it also exhibits a thinning that appears quite evident to the viewer. Additionally, the presence of the pericallosal artery in this specific region serves as a helpful landmark that further assists us in identifying and confirming the overall structure. Therefore, in these specific cases, the prognosis is very intimately connected to the degree of ventricular dilation, which in this case was severe, to any possible progression over time, which is why it is necessary to carefully monitor through regular ultrasound follow-up to any associations with cerebral anomalies and to the type of etiology and the degree of impairment of the brain parenchyma, which in this case was highly significant and extensive. Therefore, the anticipated clinical prognosis in this specific case was certainly an unfavorable outcome, precisely because of the significant functional impairment and damage of the mantle and the cerebral cortex, as well as the extreme degree of ventricular dilation, in addition to the structural alteration and severe disruption of the entire anterior compartment region. Therefore, in these cases, the primary neonatal health outcomes that are frequently observed and anticipated are cognitive and language delays, cerebral palsy, epilepsy, visual, auditory, and various types of learning disorders, all of which can ultimately lead to moderate to severe motor and cognitive disabilities. Management, therefore, is fundamentally based on monitoring, as we mentioned, through ultrasound and, of course, neurosonography, which should be repeated every 2 to 4 weeks, as well as fetal brain MRI, which was recommended to the patient, and genetic investigations such as karyotype analysis and array CGH of the fetus, along with the exclusion of infectious causes using an infectious disease panel, which in this patient was found to be completely normal. The patient had also undergone first trimester screening with a low-risk non-invasive prenatal test. It is also essential to refer the couple to multidisciplinary counseling that involves not only the obstetric component, but also the neuroradiologist, pediatric neurosurgeon, neonatologist, and of course, psychological support. Given the cephalic presentation of the fetus, detailed transvaginal scans were also performed with which confirmed the findings already highlighted during the initial ultrasound evaluation. The fetal brain MRI performed on the patient also confirmed the diagnosis of severe bilateral hydrocephalus, which had led as a complication to the rupture of the septum pellucidum and, consequently, to an alteration of the anterior compartment with communication between the two frontal horns, along with severe thinning of the cortical mantle, especially in the parieto-occipital regions. To ensure full completeness in presenting this specific clinical case, I should specify that the pregnancy was medically terminated. Upon detailed macroscopic examination of the fetus postnatally, the only physical anomaly found was the presence of low-set ears. This finding obviously has a very low ultrasound detection rate and therefore was not identified during the initial ultrasound evaluation. Furthermore, the extensive genetic analysis performed did not reveal any pathogenic chromosomal aberrations or microdeletions on the array CGH testing. Thank you for your attention.